Welcome to Reducing Nightmares in Children Using Integral Deep Listening. My name is Joseph Dillard. I am a retired licensed clinical social worker and the developer of Integral Deep Listening, often abbreviated as IDL. This course is designed as a 3-hour on-demand continuing education program for licensed mental health professionals and allied clinicians who work with children and adolescents. The purpose of this course is to introduce a structured, trauma-informed, non-interpretive approach to engaging nightmares in children. The focus is on clinical listening, narrative processing, and process fidelity rather than on diagnosis, interpretation, or outcome promises. This course is educational in nature. It is not psychotherapy, supervision, or medical advice. Participants are expected to apply the material within their professional scope of practice, institutional policies, and applicable licensing regulations. Throughout this presentation, case material is presented in composite or anonymized form. No identifying information is used. The intention is to illustrate clinical process, not to model treatment outcomes. As you proceed, you may notice that the language used in this course is intentionally careful, descriptive, and restrained. This is by design, both to meet continuing education standards and to model the clinical stance that underlies the approach being taught. Intended audience. This course is intended for mental health professionals who work with children or adolescents and who encounter nightmares, sleep disturbance, or anxiety-related nocturnal distress in their clinical practice. This includes, but is not limited to, social workers, psychologists, counselors, marriage and family therapists, school-based clinicians, and pediatric mental health providers. The material may be particularly relevant for clinicians working in trauma-informed contexts, child welfare settings, schools, outpatient clinics, and private practice. No prior training in dream work or symbolic methods is required. The protocol presented is designed to be accessible to clinicians from a wide range of theoretical orientations, including cognitive behavioral, psychodynamic, attachment-based, and play therapy-informed approaches. However, this course assumes foundational clinical competence in working with children, including basic skills in emotional regulation, rapport building, and ethical practice. Nightmares in children are often treated as a secondary or transient concern. In many clinical settings, they are viewed as a normal developmental phenomenon that children will simply outgrow. While it is true that many childhood nightmares resolve without intervention, ignoring them represents a lost opportunity to gain important feedback regarding systemic function. In addition, a significant subset of nightmares do not easily or quickly resolve without intervention. Persistent nightmares can interfere with sleep without intervention. Persistent nightmares can interfere with sleep quality, emotional regulation, school performance, and family functioning. Research and clinical observation suggests that chronic nightmares are associated with heightened anxiety, trauma exposure, attachment disruptions, and stress-related physiological arousal. Nightmares can also reinforce avoidance behaviors, such as bedtime resistance, co-sleeping dependency, or fear of being alone at night. These patterns can become entrenched and may generalize into daytime anxiety. From a clinical standpoint, nightmares offer a unique window into how a child is processing stress, fear, and unresolved emotional material. They are not merely symptoms to be eliminated, but organic feedback that can be engaged in a developmentally sensitive way. This course approaches nightmares not as pathologies, but as expressions of adaptive psychological processes that require careful, respectful listening. By the end of this course, participants will be able to achieve several specific learning objectives. First, participants will be able to differentiate nightmares from other common pediatric sleep disturbances, such as night terrors and confusional arousals. Second, participants will be able to identify trauma-informed principles relevant to working with nightmares in children, including issues of consent, pacing, and emotional containment. Third, participants will be able to describe the theoretical foundations of integral deep listening as a phenomenological and experiential listening methodology. Fourth, participants will be able to outline and apply a structured IDL-based nightmare interview protocol appropriate for children and adolescents. Fifth, participants will be able to recognize ethical considerations, developmental limitations, and contraindications associated with this approach. Finally, participants will be able to describe how this protocol may be integrated responsibly alongside other evidence-informed clinical modalities. This 3-hour course is organized into 6 major sections. We will begin with a clinical overview of nightmares in children, including prevalence, developmental considerations, and when targeted intervention may be indicated. We will then introduce integral deep listening as a listening methodology, clarifying what it is and what it is not. The central portion of the course focuses on a step-by-step nightmare interview protocol, including therapist stance, language use, and adaptations for different ages and developmental levels. We will also address ethical safeguards, cultural sensitivity, clinical boundaries, and integration with other therapeutic approaches. The course concludes with a summary, review, and post-test. The pacing is designed to support comprehension rather than rapid content delivery. You are encouraged to pause the presentation as needed. Before moving further, it is important to clarify the clinical stance that underlies the approach presented in this course. Integral deep listening emphasizes listening to experience rather than explaining experience. This distinction is subtle but clinically significant. In many therapeutic traditions, dream material is interpreted, reframed, or analyzed. In contrast, IDL brackets interpretation and focuses instead on facilitating direct engagement with dream material as it presents itself. This does not mean that meaning is denied or dismissed. Rather, meaning is allowed to emerge, if at all, from the child's own experience rather than from clinician inference. Throughout this course, you will hear repeated reminders about avoiding interpretation, reassurance, and normalization during the interview process. These reminders are not criticisms of other approaches. They are simply clarifications of this specific methodology. This stance is especially important when working with children whose symbolic language operates differently from adult abstraction. What is a nightmare? Clinically, a nightmare is defined as a disturbing dream that occurs during rapid eye movement, or REM sleep, and results in full awakening. Nightmares typically involve intense emotions such as fear, helplessness, or threat. The child is usually able to recall the dream content with varying degrees of detail upon awakening. This recall differentiates nightmares from other parasomnias. The emotional residue of the nightmare often persists after waking and may require external soothing or reassurance. In children, nightmares frequently involve themes of pursuit, attack, separation, or loss of control. However, the specific imagery is less important than the emotional experience associated with it. Understanding what constitutes a nightmare is essential for appropriate assessment and intervention. Nightmares are often confused with night terrors, but these are distinct phenomena with different clinical implications. Night terrors typically occur during non-REM sleep, usually in the first third of the night. They are characterized by sudden arousal, intense autonomic activation, and inconsolability. Unlike nightmares, children experiencing night terrors usually have little or no memory of the event the following morning. Because night terrors do not involve recallable dream imagery, approaches that rely on narrative engagement or element dialogue are generally not appropriate. Accurate differentiation between nightmares and night terrors is critical, as misapplication of interventions can increase distress rather than reducing it. Developmental stage plays a significant role in how nightmares are experienced and expressed. Younger children often describe nightmares in concrete sensory terms, with limited narrative coherence. As children mature cognitively and emotionally, dream narratives tend to become more complex and psychologically nuanced. Adolescents may articulate internal conflicts, identity concerns, or relational dynamics symbolically through nightmares. The protocol presented in this course is designed to be adaptable to different developmental levels, with language and pacing adjusted accordingly. Not all nightmares require clinical intervention. Intervention is generally indicated when nightmares are frequent, persistent, or associated with significant distress or functional impairment. Additional indicators include sleep avoidance, fear of bedtime, increased separation anxiety, daytime emotional dysregulation, or trauma exposure. Clinical judgment is essential in determining readiness and appropriateness for targeted nightmare work. In some cases, stabilization and broader trauma-focused treatment may be necessary before engaging nightmare content directly. Trauma exposure is one of the most consistently identified risk factors for recurrent nightmares in children. Trauma, in this context, refers broadly to experiences that overwhelm a child's capacity to cope, regulate affect, or integrate experience. This can include acute events such as accidents or medical procedures, as well as chronic stressors such as neglect, family conflict, or ongoing instability. Nightmares following trauma often contain themes of threat, helplessness, or loss of control. However, the imagery may be fragmented, metaphorical, or indirect rather than literal representations of the precipitating event. Importantly, the absence of explicit trauma imagery does not mean the nightmare is unrelated to trauma. Children frequently encode traumatic experience somatically and metaphorically rather than narratively. For clinicians, this underscores the importance of listening to the emotional structure of the nightmare rather than focusing exclusively on content. Traumatic memory is often stored and retrieved differently than autobiographical memory. Rather than being encoded as a coherent narrative, trauma-related memory may be fragmented across sensory impressions, affective states, and physiological responses. Nightmares provide one pathway through which these fragments can surface. The metaphorical form of the nightmare allows material that may be inaccessible during waking cognition to be expressed indirectly. From a clinical perspective, this means that nightmares should not be approached as puzzles to be solved or messages to be decoded. The ideal approach does not attempt to reconstruct historical accuracy. Its focus is on engaging the experience as it presents itself in the present moment. Attachment dynamics play a significant role in how children experience nighttime vulnerability. Sleep represents a state of reduced environmental monitoring and increased dependency. For children with insecure or disrupted attachment histories, this can amplify fear and anxiety. Nightmares may emerge as expressions of separation distress, fear of abandonment, or perceived threat in the absence of protective figures. Clinically, this may present as increased clinginess at bedtime, refusal to sleep alone, or repeated night awakenings following nightmares. When working with nightmares, it is important to consider the relational context in which the child's sleep occurs, including caregiver responsiveness and emotional availability. Not all nightmare-related distress is linked to identifiable trauma or attachment disruption. Developmental stressors, such as transitions, academic pressures, peer conflict, or changes in family structure, can also contribute to nightmare frequency. For some children, nightmares emerge during periods of rapid cognitive or emotional development, when internal resources are temporarily outpaced by environmental demands. In these cases, nightmares may function as a regulatory mechanism rather than a symptom of pathology. Clinical discernment is essential in determining whether intervention should focus on the nightmare itself or broader contextual support. Chronic anxiety and physiological hyperarousal are closely associated with disturbed sleep and nightmares. Children with heightened baseline anxiety may experience difficulty transitioning into sleep, maintaining sleep, or returning to sleep after awakening from a nightmare. Hyperarousal narrows attentional focus and increases sensitivity to perceived threat, both during life and in dream imagery. When the nervous system remains in a state of heightened activation, dream content is more likely to reflect danger-oriented themes. Any intervention targeting nightmares must therefore be attentive to overall arousal regulation, not solely to dream content. There are clinical situations in which direct nightmare engagement may not be appropriate or advisable. These include periods of acute crisis, active dissociation, unmanaged psychosis, or severe emotional dysregulation. In such cases, stabilization, safety planning, and foundational regulation skills should take precedence. Attempting to engage symbolic material prematurely can increase distress or reinforce avoidance patterns. The protocol presented in this course is designed to be used selectively and judiciously, not as a universal intervention for all children experiencing nightmares. Assessing readiness is a critical component of ethical nightmare intervention. Indicators of readiness may include the child's ability to describe emotional states, tolerate mild distress, and engage in reflective dialogue appropriate to their developmental level. Caregiver support and consent are also essential factors. The clinician must evaluate whether the child's experiences the nightmare as something they are curious about exploring, rather than something they feel coerced to confront. Readiness is not static and may change over time. Caregivers play a central role in both assessment and integration of nightmare-related work. Their understanding of the process, expectations, and boundaries can significantly influence outcomes. Caregivers should be informed that the approach emphasizes listening rather than interpretation or reassurance. They should also be prepared for the possibility that changes may occur gradually rather than immediately. Clear communication with caregivers supports consistency and reduces misalignment between clinical work and home responses. Ethical practice in nightmare work with children requires particular attention to consent, assent, and non-coercion. Children must be informed in developmentally appropriate language, that participation is voluntary, and that they may stop at any time. The clinician's role is to facilitate exploration, not to extract information or impose meaning. Maintaining clear boundaries between research, education, and therapy is essential, especially in study contexts. Ethical safeguards protect both the child and the clinician. Having reviewed the clinical context, risk factors, and ethical considerations surrounding nightmares in children, we now turn to the foundational principles of integral deep listening. The next section will introduce IDL as a listening methodology and clarify how it differs from interpretive or insight-oriented approaches to dream work. This foundation is essential for understanding the rationale behind specific interview protocols that will follow. As you listen, Notice any assumptions you may hold about dreams, meaning, or therapeutic change. The approach presented invites careful examination of those assumptions. Integral deep listening, or IDL, is a structured clinical listening methodology designed to engage dream experience without interpretation, suggestion, or imposed meaning. IDL was developed as a phenomenological approach, meaning it prioritizes direct experience as reported by the client rather than theoretical explanation. In the context of nightmare work with children, IDL functions as a facilitative process that allows dream material to be expressed and self-regulated from within the child's own experiential framework. This material is considered metaphorical rather than symbolic. Dream elements are not assumed to represent something else, which is what a symbol does. Instead, interviewed perspectives provide their own reframings and interpretations. The clinician's role is not to analyze or decode the dream, but to support the child in interacting with elements of the dream in a safe, contained, and developmentally appropriate manner. IDL can be integrated alongside many therapeutic orientations because it does not rely on interpretive assumptions or belief systems. IDL is best understood as a listening stance rather than a discrete technique. This stance emphasizes neutrality, curiosity, and restraint. The clinician listens for how experience organizes itself rather than attempting to organize it for the child. In practice, this means avoiding reassurance, reframing, normalization, or interpretation during the interview process. While these interventions may be appropriate in other therapeutic contexts, IDL temporarily brackets them to prevent contamination of the interpretations provided by the perspectives that are interviewed. The underlying assumption is that dream material contains its own regulatory logic, which can only emerge when external influence is minimized. Phenomenology refers to the disciplined study of experience as it presents itself. Phenomenological approaches surface and table temporarily our assumptions in order to listen in a deep and integral way. In IDL, phenomenology means asking the child to describe what they notice, feel, or experience without asking them what it means. Children are particularly well suited to this approach because they often relate to experience concretely rather than abstractly. By remaining focused on description rather than explanation, the clinician allows meaning to emerge organically, if and when it does. Narrative processing refers to the capacity to represent experience through images, characters, and scenarios. In children, narrative processing is a primary mode of emotional processing, not a secondary or inferior one. Nightmares often utilize imagery to express emotional states that are difficult to articulate verbally. IDL engages narrative processing directly by allowing the child to interact with dream elements as experiential realities rather than symbols. This interaction can support emotional regulation without requiring cognitive insight or narrative coherence. Traditional dream work often emphasizes interpretation, that is, assigning meaning to symbols based on theoretical frameworks or cultural assumptions. IDL deliberately avoids interpretation because interpretation introduces adult cognitive structures that may override the child's experiential process and block the emerging potentials of interviewed perspectives. Interpretation can also unintentionally suggest content, reinforce fear, or create pressure to find meaning where none is needed. By avoiding interpretation, IDL minimizes therapist influence and preserves the integrity of the child's internal metaphorical ecology. This approach aligns with trauma-informed principles of non-imposition and client agency. Language choice is central to the IDL process. Questions are phrased to invite description rather than explanation. For example, instead of asking, "Why do you think the monster is there?" the clinician might ask, "Monster, what do you like about yourself?" This subtle shift keeps the focus on experience rather than causality, meaning making, or the perspective of the interviewed child. Consistent use of this language reduces cognitive load and supports emotional containment. Neutrality in IDL does not mean emotional detachment. It refers to the clinician's commitment to not privileging any particular outcome, emotion, or narrative. Neutrality allows all aspects of the experience, including fear, anger, or confusion, to be expressed without correction. This stance can feel counterintuitive for clinicians trained to soothe or reassure. However, neutrality often creates a deeper sense of safety by reducing performance pressure and expectation. IDL assumes that emotional regulation can occur through structured engagement rather than control or suppression. By interacting with nightmare elements in a contained setting, the child experiences agency within the metaphorical field. Regulation emerges as the nervous system updates its relationship to the perceived threat. Importantly, this process does not require desensitization, exposure hierarchies, or cognitive restructuring. The clinician's role is to maintain the structure within which this engagement can unfold safely. IDL is designed to be modality agnostic. It can be integrated with cognitive behavioral approaches, play therapy, attachment-based models, and psychodynamic frameworks. IDL does not replace existing treatment plans, but can be used selectively to address nightmare-related distress. Because it avoids interpretation, it reduces the risk of theoretical conflict across modalities. Integration should always occur within the clinician's scope of practice and training. With these foundations in place, we now move to the practical applications of IDL in the context of childhood nightmares. The next section will outline the step-by-step nightmare interview protocol, including therapist stance, language, and common clinical decision points. As we proceed, consider how this approach differs from familiar interventions and what adjustments it may require in your clinical posture. The emphasis will remain on process clarity and ethical application. This section introduces the structured IDL nightmare interview protocol used with children. The protocol is designed to reduce nightmare distress by facilitating safe engagement with symbolic material, not by interpreting or explaining it. Each step is intentionally simple, repeatable, and adaptable to developmental level. Fidelity to the sequence matters more than stylistic variation. The clinician's role is to maintain structure, neutrality, and containment throughout the process. The interview begins by establishing psychological safety and clarifying consent. Children should be informed in age-appropriate language that they are being invited to talk about a dream and that participation is optional. It is essential to emphasize that there are no right or wrong answers and that the child may stop at any time. This framing reduces performance anxiety and reinforces agency. Consent is an ongoing process and should be reaffirmed as needed throughout the interview. The child is invited to describe the nightmare briefly, without elaboration or prompting. The clinician listens without interruption, clarification, or interpretation. The goal is not to gather exhaustive detail, but to identify the primary figures, settings, or emotional focal points. If the child struggles to articulate the dream, gentle prompts such as, "What do you remember most?" may be used. Avoid questions that imply causality or meaning. After the brief description, the child is invited to choose one element of the nightmare to focus on. This element may be a character, object, or place. Allowing the child to choose reinforces autonomy and reduces the risk of overwhelm. The selected element becomes the focal point for the remainder of the interview. If the child is unsure, the clinician may offer neutral options without preference. The child is invited to imagine being the selected nightmare element. This is done gently and without pressure, often using language such as, "If it's okay, let's pretend you are this part of the dream." The clinician does not frame this as role play or imagination training, but as an experiential exercise. The goal is not realism, but engagement. Speaking and answering questions in the interview as the dream element, not from the child's perspective, is key. The primary focus of the clinician is to make sure the dream element, not the child's waking perspective, is answering. If the child declines, the interview can pause or shift focus. Once a child has taken the perspective of the nightmare element, questions often focus exclusively on experience. Examples include, "Where are you now, character?" Or, "What do you like or dislike most about yourself?" The clinician follows the child's responses closely, allowing the experience to unfold without direction. Silence is acceptable and often productive. Since the interviewed element is imaginary, it can change itself in any way it wants. No change can be as important as change. For example, the child may need to own the power and anger of the monster. Make sure any change is desired by the character and not interjected by the child. This is because they may want different things. What the child wants is important, and the interview is an opportunity to hear the preferences of the interviewed character. Those of the child can be heard later. Responses to the life change question give voice to perspectives on living that otherwise may not be heard. The character may or may not have thoughts on why the dream happened. The clinician follows the child's responses closely, allowing experience to unfold without direction. Silence is appropriate and often productive. Certain forms of language are intentionally avoided in ideal interviews. These include interpretation, reassurance, normalization, or reframing. For example, statements such as, "That sounds scary, but you're safe now," may prematurely interrupt the child's process. Similarly, asking why questions can shift the child into cognitive explanation rather than experiential awareness. Avoidance of these interventions supports containment and neutrality. As the child engages with the nightmare element, shifts may occur naturally. The image may change, soften, move away, or become less threatening. The clinician does not encourage or direct these changes. Regulation is understood as an emergent process rather than a goal to be achieved. If no change occurs, the interview remains valid and complete. When the engagement feels complete, the clinician gently guides the child back to their own perspective. This may involve simple grounding questions or a brief pause. The transition should be calm and unhurried. Ask the child, "What did you hear yourself say?" Repeat back to the child what they heard, without adding interpretation. This step supports integration by grounding the perspective of the interviewed element in waking awareness. The focus remains on present moment safety and regulation. The interview is closed by thanking the child for participating and acknowledging their effort. No conclusions or interpretations are offered. The clinician may remind the child that dreams can change over time and that support is available. The closure reinforces containment and reduces residual arousal. Follow-up plans should be discussed with caregivers separately. Common errors include over-questioning, premature reassurance, and subtle interpretation. These often arise from the clinician's desire to help or to reduce distress. These often arise from clinicians' desire to help or to reduce distress quickly. Awareness of these tendencies allows for intentional restraint. The protocol is most effective when the clinician tolerates uncertainty and incompleteness. Practice and supervision support skill development. When younger children are interviewed, language should be simplified and sessions shortened. Visual aids or drawing or work with clay may be incorporated if consistent with the child's preferences. The core structure of the protocol remains unchanged. Flexibility should not compromise neutrality or agency. Developmental appropriateness is key. Adolescents may approach the protocol with skepticism or self-consciousness. Clear explanation of the process and its rationale can increase engagement. Respect for autonomy and privacy is especially important. The clinician should avoid appearing patronizing or overly directive. Adolescents often benefit from the same neutrality afforded to younger children. Caregivers should receive general information about the process without specific dream content. This protects the child's privacy and autonomy. Caregivers may be advised to observe changes in sleep patterns, mood, or behavior without pressuring the child for details. Reinforcing a calm, non-intrusive response at home supports integration. Any concerns should be addressed collaboratively. This concludes the overview of the ideal nightmare interview protocol. In the next section, we will examine ethical considerations, integration with other clinical approaches, and boundaries of appropriate use. These considerations are essential for responsible application and professional accountability. As always, clinical judgment and scope of practice guide implementation. Trauma-informed practice requires attention to pacing, choice, and emotional safety. In nightmare work, this includes monitoring signs of overwhelm, dissociation, or escalating distress. The ideal protocol emphasizes containment by limiting scope, duration, and therapist influence. If a child becomes dysregulated, the interview should pause or stop without attempting to push through. The clinician's responsibility is to prioritize safety over completion of the protocol. Ideal nightmare interviews are not appropriate in all clinical circumstances. Contraindications may include acute psychosis, unmanaged dissociative symptoms, or situations involving immediate safety risk. Caution is also advised when a child lacks basic emotional regulation skills or when caregiver support is inconsistent. In such cases, foundational stabilization work should precede any symbolic engagement. Clinical judgment and scope of practice guide decision making. Cultural context shapes how dreams are understood, expressed, and valued. Ideal avoids imposing cultural interpretations or symbolic frameworks. Clinicians should remain attentive to language, imagery, and meanings that arise within the child's cultural world. Developmental sensitivity includes adapting language and pacing without altering the core protocol. Respect for diversity is integral to ethical practice. IDEO can complement cognitive, behavioral, and skills-based interventions by addressing experiential dimensions of distress. While CBT focuses on thought patterns and behaviors, IDEO engages experience directly without restructuring or reframing by the therapist or child. These approaches can coexist when applied sequentially rather than simultaneously. Integration should remain transparent to the child and caregiver. Each modality serves distinct therapeutic functions. Play therapy and IDL share an emphasis on child-led expression. IDL differs in its structured neutrality and focus on perspective taking within dream material. Play-based elements may support engagement, provided they do not introduce interpretation or direction. Clinicians should clarify when they are shifting between modalities. Maintaining conceptual clarity supports ethical practice. Attachment-oriented approaches emphasize relational safety and co-regulation. IDL supports attachment work by respecting autonomy and minimizing intrusion. Caregiver involvement is structured to support containment rather than interpretation. Attachment dynamics may inform timing and pacing of nightmare work. Integration requires attention to relational context without conflating roles. When IDL is used in research contexts, boundaries between research and therapy must be clearly defined. Participants should understand whether the interview is part of clinical care, research, or both. Data collection procedures should not interfere with therapeutic responsiveness. Transparency protects participants and supports ethical integrity. Institutional guidelines and informed consent processes apply. Accurate documentation supports both clinical accountability and research validity. Interview responses should be recorded verbatim or using structured notes. Deviations from protocol should be noted without judgment. Honest documentation allows for meaningful evaluation and learning. Data security and confidentiality must be maintained at all times. Clinicians must apply IDL within their professional scope of practice and licensure status. This course provides education, not certification, or authorization to practice beyond existing credentials. Consultation or referral is appropriate when clinical complexity exceeds one's competence. Ethical responsibility includes knowing when not to intervene. Professional humility supports safe practice. Ethical application of IDL rests on consent, containment, neutrality, and respect for the child's autonomy. The protocol is designed to minimize harm and maximize safety. Integration with other approaches should be thoughtful and transparent. Ethical safeguards are not optional, they're foundational. These principles guide responsible clinical use. This course has examined nightmares in children from a clinical, developmental, and trauma-informed perspective. We reviewed risk factors, assessment considerations, and ethical safeguards. Integral deep listening was introduced as a structured listening methodology emphasizing neutrality and child agency. The IDL nightmare interview protocol was presented step by step. Integration with existing clinical approaches was discussed. IDL is a listening methodology, not a diagnostic tool. It is not interpretive, suggestive, or exposure-based. IDL does not replace comprehensive treatment planning. It is one option for addressing nightmare-related distress within appropriate clinical contexts. Clear understanding supports ethical application. Key takeaways include the importance of neutrality, containment, and developmental sensitivity. Nightmare reduction does not require meaning-making or insight. Agency and experiential engagement support regulation. Clinical boundaries protect both child and clinician. Clinical judgment remains central. Participants are encouraged to reflect on how this approach aligns with their existing clinical orientation. Consider where neutrality may support or challenge current habits. Application should proceed gradually and thoughtfully. Consultation and continued learning support competence. Reflection deepens integration. To receive continuing education credit, please complete the post-test and course evaluation as directed by the CE provider. The evaluation supports quality improvement and accountability. This concludes the educational content of the course. Clinicians who are interested in functioning as co-authors in research on reducing nightmares in children may contact the author at joseph.dillard@gmail.com. Thank you for your attention and professional engagement. We appreciate your commitment to ethical, child-centered clinical practice.